It's a pleasure to introduce Alice Sheridan, who's one of the co-directors of the course. Alice has had a distinguished career at BMC, MGH, and for several decades now at the Brigham, where until recently she was our program director for the fellowship program. She had an excellent research career in AKI mechanisms and was for many years an editor at Up to Date, and then returned to the Brigham some time ago. I'm not sure exactly when, but she's an excellent clinician, and it's a pleasure to have her give this talk on acute kidney injury syndromes.
Thank you, David. Hi, everybody. I'm here to talk to you about acute kidney injury syndromes. And today I am speaking solely to you as a clinician. I have no relevant financial relationships with ineligible companies. And this is a bit of a springboard. I know Joe Bonventre gave you an excellent review of the definitions of AKI. I will obviously try not to be redundant here. The objectives of my talk are to define the common syndromes that underlie acute kidney injury, while recognizing the limitations of the definitions, and to describe the clinical presentation and prognosis of a few select syndromes. It is quite possible I will not get to all the cases that are at the end of your slide deck, but I'll try to stick to the most interesting cases. So how are we defining AKI? Again, not to be redundant. AKI is a group of syndromes that are all characterized by an acute decrease in GFR, and the degree of reduction in GFR and or urine output currently provide the sole criteria for diagnosis. This was first developed by the Acute Dialysis Quality Initiative, revised by the Acute Kidney Injury Network in 2007, and finally, and remarkably most recently published by KDIGO in 2012. There is a new KDIGO guideline draft that was issued in March. I stress this is a draft that was sent out to the community for review, so it is not set in stone. Many of you have likely seen it and perhaps reviewed it. Clearly, this attempts to address the limitations that were so well defined by Dr. Bonventre in the prior talk. So here are the definitions, the current criteria as defined by KDIGO. You just saw this slide in the previous talk, so I won't spend any time discussing the 2012 criteria. The 2026 draft included criteria that now suggest using the cystatin C. KDIGO suggests, 2B suggestion, using the cystatin C in settings where the creatinine is likely to be unreliable. I'll discuss this further in a few slides, but they are defining AKI by, in addition to urine volume, creatinine parameters, by an increase in the cystatin C by 1.5 times the baseline, known or presumed to have occurred within the past 7 days. 2026 KDIGO, again the draft, also included a practice point. This is a non-graded consensus that incorporates structural abnormalities. That is to say, those biomarkers that Joe just discussed with you, if they're available. And unfortunately, and in many places, they are not yet widely available. So clearly, KDIGO is attempting to address the limitations in the current biomarkers and the current criteria for AKI. Urine output is actually a fairly accurate, reliable signal for AKI, providing it is being monitored. At the Brigham, at least, it's actually surprisingly difficult to maintain accurate I's and O's until the patient gets a diagnosis of AKI. It's It's a little bit better. It's better in the OR, clearly. It's better in the ICU. And on patients on the cardiology floors, the urine output appears to be followed far more closely. The urine output imparts important prognostic information. A number of studies have shown that without any increase in the creatinine, oliguria is associated with an increased mortality risk. In a retrospective study published in 2021, among over 5,000 patients, the 90-day mortality was significantly higher in patients who showed oliguria at any time during their hospital stay compared with those who did not. And this was independent of the creatinine. Clearly, the worst outcomes were identified in those who had both oliguria and an increased creatinine. Two meta-analyses, and actually more than that now, most recent, have since been published that show that decreased urine output in the OR predicts AKI by the traditional KDIGO criteria. Following non-cardiac surgery in 9 eligible studies with over 18,000 patients, those patients with intra-op oliguria had a considerably greater, roughly twofold increased risk of post-op AKI defined by the traditional criteria. They also had an increased risk of renal replacement therapy requirement and in-hospital mortality. The increased risk of AKI has since been confirmed in a much larger meta-analysis that included 50,000 patients. So again, as Joe pointed out, the reason we need a better, earlier biomarker is that the early identification of AKI allows for interventions. The sooner you catch this, the more quickly you can turn it around, is the presumption. And this was confirmed, suggested by the PREV-AKI study. This was a randomized single-center trial, including about 1,000 patients, that identified high-risk patients using selected biomarkers who were undergoing cardiac surgery. And what they found was a bundle of interventions, including optimization of the volume status and hemodynamics, avoidance of nephrotoxic drugs, and the prevention of hyperglycemia, reduced the incidence and severity of AKI. It did not reduce the need for dialysis or the length of stay. This has now been followed up with a meta-analysis that approximately doubled the amount of patients and was able to demonstrate that a kidney protection strategy is able to reduce the AKI risk in a biomarker-enriched pool of high-risk patients. Another single-center study suggested that it's actually difficult to adhere to the defined interventions that have been shown to be protective. Real-time monitoring of the urine output may also allow earlier detection, and a number of technologies are being developed to allow this. The Acute monitoring system has been shown to allow the early identification. It's the smart Foley placed after anesthetic induction, continued until discharge from the ICU, continuously records the urine output and has been shown to detect AKI about a day before the KDIGO criteria are fulfilled. So let's get to the cystatin C. Again, the 26 draft guideline suggests using the cystatin C rather than the creatinine when the creatinine is expected to be less accurate. Well, we know the creatinine is likely less accurate among patients with reduced muscle mass, such as those with neurologic conditions, muscle wasting, spinal cord injury, certainly an above-the-knee amputation, and among those patients that are treated with agents that alter the secretion of creatinine, such as trimethoprim. However, even without these known confounders, among hospitalized patients with AKI, the cystatin C is just a better way to estimate the GFR. And these data have been emerging over the last few years. In the Haynes study, this was published in 2023, cystatin C eGFR and creatinine eGFR were compared to each other and to iohexol clearance in an ICU population. This was an excellent study. It was a small study, fewer than 40 patients, but they measured the GFRs on admission in tandem throughout the ICU stay and then on discharge. And at select times, they did an iohexol clearance. And what they found was at the beginning of the ICU stay, the GFRs, estimated GFRs, were roughly comparable. As the ICU stay progressed, the eGFRs diverged. And eGFR by creatinine became wildly inaccurate and rather grossly overestimated the iohexol clearance. This was so pronounced that on discharge, again, it was a small study, but among 15 patients who developed AKI by KDIGO criteria and survived to be discharged, 10 of them were determined by cystatin C to have a persistently reduced GFR below 60. By contrast, the creatinine eGFR only identified 2 of these patients. And this is important. These patients clearly should be marked for follow-up for the sequelae of acute kidney disease at that point, and likely CKD. So it appears to be a better marker. Now, the question is, why is it better? The likelihood is that one of the reasons is that cystatin C has a much smaller volume of distribution compared with creatinine. Cystatin C is only in extracellular fluid. Compared with total body water, which is the volume of distribution for creatinine. Because of the smaller volume of distribution, cystatin C reaches a steady state more quickly, and you'll detect doubling far more quickly. This is important. We all know when the GFR changes, a functional biomarker that estimates GFR it needs to be in steady state before you can make sense of it. Cystatin C gets to steady state much more quickly and allows for a more accurate determination of the GFR. So that is the likely reason: smaller volume of distribution and a faster time to doubling. And this was actually shown in a modeling. A mathematical model was developed by Hooper et al. And published in 2025. And what they did was took theoretic numbers of a baseline estimated GFR and calculated how long would it take to get to steady state. It's in the setting of a low clearance. And what they found was with cystatin C, there is earlier detection of AKI, roughly 12 to 24 hours, compared with 12 to 72 hours for creatinine. And this is obviously important. Early recognition allows for early intervention. This was clinically demonstrated in a network meta-analysis by Lan et al. Published in 2023. This was a collection of about 2,000 patients, and they looked at multiple biomarkers, both structural, the ones that Joe discussed with you, and functional, the cystatin C, and compared to what was considered the gold standard AKI 2012 criteria And they found that the cystatin C has the overall best performance, predictive performance, using a hierarchical area under the curve analysis. What is perhaps, I might suggest, almost equally important was this study from Mayo, actually published in 2018, that the cystatin C also predicts recovery before creatinine. This was a very lovely study of 63 patients who had severe stage 3 AKI that was non-oliguric. It's an important distinction. However, of the 63, 21 were on dialysis. And the cystatin C started to decrease approximately a day earlier in about 68% of patients. And among those 21 who were on dialysis, the cystatin C dropped in 19 of them. Now, you would say 24 hours, how important is that? I would suggest that it's very important. These are the patients that we are following closely for the ongoing need to dialyze. These are patients that we put on our second shift so that we can check the creatinines, and we follow over weekends so they have 2 days in between dialysis. These are the folks that we are trying to arrange outpatient dialysis, which is a problem unto its own in terms of how do you follow them. If we could get even 24 to 36 hours seeing a recovery, I suggest it would make a huge difference. The reason, again, it's the smaller volume of distribution. The cystatin C gets to a steady state. And if you're not in steady state and the GFR is recovering, you will underestimate your clearance. So in addition, it's possible, and I did not include this reference because it's from the ESRD literature in chronic dialysis. Using the cystatin for recovery may be less confounded by dialysis. Cystatin C is less well dialysable. It is a much larger molecule than creatinine, and the percentage reduction is less. Not that much, maybe 40% versus 60%. However, because of, again, the small volume, it rebounds far more quickly. And in one study, and again, this was dialysis patients, the cystatin C rebounded to within 12 hours to 95% of the pre-dialysis rate, of the pre-dialysis value. And in 24 hours, that's the day after dialysis, it was back to 100% of the pre-dialysis value. So it's less confounded by removal during dialysis and is more likely to reflect the possible change in clearance. So I'm waiting for this to be repeated in the acute kidney injury model. It has not yet, as far as I know. So let's switch somewhat to the epidemiology. It is sobering. In high resource settings, AKI occurs in 20% of hospitalized patients. It is a risk factor for mortality. Among patients with sepsis, there's 3 to 5-fold increase in 60-day mortality. And the recovery determines the prognosis. Early reversal is associated with a greater than 90% survival at 1 year, whereas no reversal is associated with a less than 40% survival. Hospital-acquired is a different entity from community-acquired AKI. Causes, risk factors, and outcomes are distinct. Community-acquired AKI presents at the time of admission or is recognized shortly thereafter, and it results from factors that are present in the community. Hospital-acquired AKI develops after 48 hours. And as we know, it's due to therapeutic or diagnostic interventions or the sequelae of another illness. Most studies and most clinical practice guidelines pertain to hospital-acquired AKI. And in fact, the data that informs our guidelines were derived in hospitalized patients from high-resource countries like our own. This is important because the majority of AKI actually occurs in lower resource settings in developing countries and is community acquired. With that caveat, what are the common causes of hospital AKI that we see as practicing nephrologists? Well, a weekend on consults, and most of us will see this. Most of it is pre-renal ATN. It's followed by, you'll see cardiorenal, you'll see drug-induced interstitial nephritis, not so much RPGN, a little bit depending on your demographic, hepatorenal. The crystallopathies and obstruction, particularly obstruction, will depend on your demographic to some degree. This was actually studied in the AKI EPI study. This was the first international multi-center study that reported on the occurrence of AKI in ICU patients, included close to 2,000 patients. AKI occurred on day 1 of admission in 57% of patients, and in 23% of patients, 23% of these patients required kidney replacement therapy. The most common causes was sepsis, 41%, hypovolemia, 34%. Well, there's your 75% right there. This was followed by drug-related causes, AIN in 14, or ATN, cardiogenic shock at 13%. Hepatorenal, much less at 3%, and obstruction at only 1.4%. Again, I stress that these data are in the hospitalized patient. What about community-acquired AKI? Well, as I mentioned, it turns out most cases of community-acquired AKI are in developing countries. The fact is, the vast majority of AKI is in lower middle-income countries just because a disproportionate percentage of the population resides in these countries. The causes of AKI, broadly, infection, volume depletion, from diarrheal illness, poisoning, animal bites, venomous stings, poor obstetrical care, and heat illness. 2016 meta-analysis run by Ravindra Mehta included studies from high, low, and middle-income countries using the KDIGO criteria, and it showed that the incidence in lower middle income is actually similar to the high income countries. So the net number is much higher in developing countries, but the incidence is roughly the same. It's as before, as it has been shown in multiple studies, AKI conferred increased mortality in community-acquired AKI. And in, as we know, hospital-acquired AKI. The causes are different and the risk factors are different. Among high-income hospitalized patients, the risk factors include age, comorbidities such as diabetes, cardiovascular, and CKD. The lower or middle-income countries, community-acquired, younger age, few comorbidities. So what about community-acquired in high-income or developed countries? Well, this is not well studied. This is our outpatient population. AKI or an elevated creatinine is generally, it's often incidentally detected. Yes, it's a follow-up from your hospital AKI. It's incidentally detected on lab values, and you don't really know the duration. Because how often does a primary care doc check the creatinine? So more commonly, this is going to fall into the category of acute kidney disease, meaning 3 months or less, or chronic kidney disease that this has not been identified yet. Generally, the duration is unknown. It is in this patient that two things are going to yield the diagnosis. One is biopsy is invaluable. And in general, I believe you do end up doing it using the biopsy more in your outpatient population. The second thing is the history is critically important here because often you get the biopsy and you still need to go back and trace what's going on before you can piece together, make sense of the biopsy. So with that, and I apologize, we only have 5 minutes left, and I don't want to detract from the question time because I know you have them. I'm going to select a couple of patients here, and we'll go through them. And obviously, I would be very happy you have the slides and you have the references, and I'd be happy to discuss them individually. The first patient is a 65-year-old gentleman. It has CKD 3A, status post-lung transplant on a calcineurin inhibitor. The CKD was attributed to the calcineurin. He then develops a bump in creatinine that clearly occurred over the course of 3 months. And by his history, during this time, he had absolutely unremitting diarrhea that had been evaluated at an outside hospital, 2, in fact, outside hospitals, and attributed to small bowel intestinal bacterial overgrowth. He sustained a 30-pound weight loss during this time. He saw a couple of GI doctors and was treated with both Augmentin and rifampicin with some abatement of the diarrhea. He was actually admitted to Brigham. He was pre-renal. He was given volume. He had a creatinine that was about 6 or 7. It got better. It came down to about 4. He was discharged. Comes in to see me. He is no longer having diarrhea. He stopped the antibiotics. His diet is completely back to normal, except he's now drinking spinach smoothies that his family is feeding him in order to bulk up, to get him back to health. He is on vitamin C gummies and occasionally takes as many as 3 to 4 a day in an effort to recover his previous health status. Completely euvolemic on exam, and his creatinine is unfortunately remains elevated at 3.54. You elect to do a kidney biopsy, and the light microscopy shows widespread tubular injury, distended lumina, many intraluminal birefringent crystals under polarized light. There is interstitial fibrosis, but no active cellular infiltrate, and this shows a representative micrograph. So what's the likely cause of his AKI? Now, I know you have this in the syllabus, so I won't, you don't need to respond except think about it. Well, it's oxalate nephropathy. Clearly the ATN from volume depletion would have recovered by now. It's unlikely he would have such severe injury. The tubular injury observed on biopsy is common with oxalate. Drug-induced interstitial nephritis, no. The interstitial nephritis is absolutely seen with oxalate, and over time, fibrosis. This patient did not have an active interstitial cell infiltrate. Acute phosphate nephropathy, no. Phosphate crystals are not birefringent under polarizing light, and unlike calcium oxalate, they're identified with the von Casa stain. So, oxalate nephropathy, I think it's underdiagnosed. Its corollary is stones, and often the hint that somebody could have oxalosis is stone disease. Generally, in the adult population, it's going to be secondary, not primary, and it commonly results from bowel surgery, prolonged antibiotics, particularly for this small bowel overgrowth. It can be made worse by excessive intake of dietary oxalate and the precursor of ascorbic acid, vitamin C, generally in the setting of volume depletion. Oral antibiotics, they alter the bowel flora with decreases in Oxalobacter formigenes, which degrades dietary oxalate and butyrate forming bacteria. which regulates the oxalate transporters. As a result, you get widespread oxalate absorption and hyperoxaluria that causes both stones and oxalate nephropathy. So most of the data are from nephrolithiasis. It's easier to count stones than do a kidney biopsy. Risks, Roux-en-Y, bariatric surgery, bowel disease. I won't go through this. A systematic review showed for oxalosis showed 88% had the risk factor of fat malabsorption. How do you treat it? Well, I can defer to Gary Curhan's talk. You treat the way you would stones, oxalate stones. Fluid, 2.5 liters of urine daily, if not 3. A low oxalate diet, a low fat diet, increased oral calcium, and probably citrate, although there are no data published to support this in oxalosis. I'm going to stop, unfortunately. I would love to go through these cases, but I need to stop now. Because I would like to leave the time for questions and answers, and these cases do take a while. And so I'm going to sum the take-home messages. The criteria that define AKI are imperfect. The prognostic importance of urine output is increasingly appreciated. Cystatin C is a better marker than creatinine, and we keenly await the structural biomarkers that are around the corner. Multiple conditions underlie AKI and AKD. Biopsy is commonly required, but the history is equally important. Thanks very much, everyone. I look forward to your questions.